is highly relevant to our day-to-day practice. I'm sure his insights will deepen our understanding and guide us in better management of liver disorders through homeopathic principles. On behalf of IFPH, I extend my heartfelt gratitude to our respected speaker and a warm welcome to all participants who continue to support this wonderful academic journey. Let us make this session interactive and fruitful. Thank you. Now, I respectfully invite Professor Dr. RINKU BISHWAS to begin his journey.
Thank you, ma'am. Am I audible to all of you?
Yes, sir.
Good evening to all of you. At first, I want to thank Dr. Tanesh sir, Dr. Sani sir to give me opportunity to speak in IFPH 2024 lecture or seminar. Today my topic is hepatic disorders and homeopathy. Previously, I already given lectures on tuberculosis, GIT disorders, depression, anxiety, and one of my lectures is on CVS disorders. So this is my fourth or fifth lecture in this forum. So this is very good efforts by this forum to promote the homeopathy, to develop the homeopathy and awareness of the homeopathy amongst the peoples. So without wasting time, I start today's lecture, hepatic disorders. At first, we know about the liver functions, metabolism, carbohydrate, fat and protein, essential for the metabolism. Secretory functions, it secretes bile, bile acids, salts, pigments, etc., which is essential for the digestion and various synthesis functions. Secretory, bilirubin, drugs, toxins, these products are essential for the various digestive as well as excretory functions. So these are the major functions, storage as well as detoxification functions. These are the functions of liver. So today we will discuss about the major hepatic disorders. It is not possible to discuss all hepatic disorders in one lecture. Today I cover jaundice, cirrhosis of liver as well as hepatitis in this my lecture. So jaundice is the main disease of liver or hepatic disorders. It is yellowish discoloration of the skin, mucous membrane due to hyperbilirubinemia. Normal serum bilirubin level is 0.2 to 0.8 milligram per deciliter. From the level of 1 to 2 milligram percent, it is called latent jaundice, and above the 2 milligram percent, it is called jaundice or icterus. Destruction of before knowing about the jaundice, it is important to know about the metabolism of bilirubin. So, destruction of the old RBCs, senile RBCs, it divide into the heme and globin. In the presence of heme oxygenase, it convert into the biliverdin. In the presence of biliverdin reductase, it reducted in the bilirubin, which is unconjugated from the bilirubin, and bilirubin bound to the albumin, and in serum, it again divide separate from the bilirubin to the albumin and attach with the glutathione S transferase and form the unconjugated bilirubin glutathione S transferase. And it combined with the bilirubin UDP glucorosyl transferase with form bilirubin monoglucuronide, and monoglucuronide again unite and form the diglucuronide, which is called conjugated bilirubin. This is the normal metabolism of bilirubin. It energy depends process and excreted through the bile. Intestinal bacteria convert the bilirubin into the urobilinogen, and it is responsible for the stool color, that is stechobilinogen, and color of the urine through the urobilinogen. It also resecreted into the bile in the formation of new bilirubin on again resynthesis of the bilirubin. This is the cycle of bilirubin metabolism. Main causes of the jaundice: increased bilirubin production, decreased hepatic uptake, decreased hepatic conjugation, decreased excretion of the bilirubin into the bile, and obstruction it out of flow. On this basis, on this pathogenesis, it is divided into the pre-hepatic, hepatic and post-hepatic jaundice. Increased bilirubin production. due to the excessive hemolysis, due to the over breakdown of the RBCs, increased bilirubin production. Sometimes we can see in neonate physiological jaundice or in pathological jaundice and adult age due to the excessive hemolysis is the main cause of increased bilirubin production. Decreased hepatic uptake. This increased bilirubin or hyperbilirubinemia, sometimes it is doesn't properly uptake by the liver. Decreased hepatic conjugation due to the absence of glucose S transferase or essential enzymes. There is sometimes doesn't convert into the monoglucuronide or diglucuronide. So decreased hepatic uptake conjugation may also causes unconjugated hyperbilirubinemia or decreased excretion of the bilirubin into the bile due to obstructive jaundice, due to any obstructive cause in the bile canaliculi may produce conjugated hyperbilirubinemia or regurgitation of the bilirubin. And sometimes obstruction in the outflow due to any gallstone and biliary atresia or any cystic duct obstruction, whatever the cause, it may produce atresia. Classification of jaundice according to this cause, it divided into the unconjugated hyperbilirubinemia, conjugated hyperbilirubinemia. If there is free bilirubin level increases, it is called unconjugated hyperbilirubinemia. And after the conjugation, if it regurgitated or due to any obstructive cause, it accumulated or increased, it is called conjugated hyperbilirubinemia. So in this site, there is 3 types of jaundice: pre-hepatic, hepatic, and post-hepatic. The causes which interfere the normal union of the bilirubin in the liver or essential enzymes lack may causes unconjugated hyperbilirubinemia, and sometimes there is after the obstruction in the cause in the line of bile, or sometimes due to the obstructive jaundice, if there is lack to flow in the intestines also may produce conjugated hyperbilirubinemia. Predominantly unconjugated hyperbilirubinemia may be causes hemolytic cause, a caloric cause, prehepatic jaundice. Increased bilirubin production due to any of the hemolytic disease, that is sickle cell anemia, intravascular or extravascular causes. Decreased hepatic uptake due to drug sensitivity, prolonged starvation, and whatever the cause. Decreased conjugation. There will be the lack of defect of enzyme. Sometimes it is seen in the congenital jaundice. It is gluconesis S transferase deficiency may cause Crigler-Nazar syndrome. Pathogenesis, increased destruction of the RBCs. There is over destruction of the RBCs due to any hemolytic cause or infection. If there is excessive destruction of the RBCs, causes excessive breakdown into the heme and globin, and heme portion may reducted into the bilirubin. So it is causes hyperbilirubinemia. Liver cannot able to conjugate all this bilirubin, so unconjugated form of the bilirubin may be increased in the serum, causes unconjugated hyperbilirubinemia. These unconjugated hyperbilirubinemia having affinity to deposit into the elastic tissues of the body, in the eyes, in the palms, in sclera, and causes this type of yellowishness in the eyes, in sclera or conjunctiva, paleness of the skin and skin, elastic tissues, etc. Paleness of the urine, excessive pale urine, sometimes associated with the hyperbilirubinemia. Lab diagnosis: total bilirubin level increased, unconjugated hyperbilirubin increased, and conjugated bilirubin in or total bilirubin become normal. Assess the condition of the liver also: transminase level, SGOT, SPT level, alkaline phosphatase. These all are LFT liver function tests. They are sometimes increased in the liver disease, but in unconjugated hyperbilirubinemia they are normal because it is due to the hemolysis, not due to the hepatic disorders. So in this condition, this LFT functions may be normal. Urine, there is absence of bilirubin because it is not forms in the form of urobilinogen and not freely released through the urine. So absence of the bilirubin in the urine. Stool examination, increased stechobilinogen in the urine. So color of the stool become dark brown or yellowish. Conjugated hyperbilirubinemia. Failure of the normal amount of the bile to reach in the duodenum due to any atresia, due to any obstruction or gallstones causes conjugated hyperbilirubinemia. In this condition, the bilirubin, conjugated bilirubin become regurgitated and increased level of conjugated bilirubin due to the cholestasis, accumulation of the bile in the liver cells, or biliary plaque, biliary passes, biliary lakes, biliary pool. Biliary passes, two types: intrahepatic cholestasis and extrahepatic cholestasis. In the liver, if there is obstruction found, it is called intrahepatic cholestasis, and outside the liver is obstruction found or stasis of the bile, it is extrahepatic cholestasis. Intrahepatic cholestasis caused due to the defect in the impaired hepatic excretion of the bile, and defect is in the biliary canaliculi of the hepatocytes, causes hereditary Dubin-Johnson syndrome. It is also the form of conjugated hyperbilirubemia found in the neonates or childhood period. Dubin-Johnson syndrome, Rotor syndrome, intrahepatic atresia or maldevelopment of the biliary canaliculi. Acquired causes includes viral hepatitis and alcoholic hepatitis. Clinical features: bilirubinemia, increased level of the serum bile acids, prothrombinemia, hyperlipidemia. Grossly liver will be enlarged, greenish in color and soft in the consistency. Microscopically, if we see bile plugs seen in the canaliculi, it is due to the atresia and obstruction of the bile canaliculi, and sometimes bile plugs form in the liver. It seems dark greenish or bluish presence. Feathery degeneration of the cytoplasm, periportal fibrosis may be seen. Proliferation of the intralobular ductules may be seen. Extrahepatic cholestasis, mechanism: obstruction of the large bile ducts outside the liver or within the porta hepatis cause the gallstones, carcinoma head of the pancreas, congenital atresia of the extrahepatic ducts may causes extrahepatic cholestasis. This obstruction found outside the liver, maybe in bile duct, in the porta hepatis, due to the gallstone. If there is obstruction in the flow of the free flow of the bile, and sometimes there is head of pancreas, maybe cancerous or carcinoma head of pancreas, or sometimes congenital atresia may causes extrahepatic cholestasis. Mechanism: obstruction of the extrahepatic bile duct, retrograde extension of the bile, so bile become regurgitated, dilatation of the bile ducts, rupture of the canaliculi and extravasation of the bile, focal necrosis of the hepatocyte may be seen. Clinical features: conjugated hyperbilirubinemia. In this condition, normal or free bilirubin may be normal, but conjugated form of the bilirubin in the serum may be increased due to a regurgitation. Elevated bile acids, hyperlipidemia may be seen. Malabsorption of the fat soluble vitamins, especially A, D, E, K, lead to the vitamin K deficiency. Heavy greasy stool may causes steatorrhea. Stool absence of the bilirubin, and stool become clay colored. Because there is absence of stechobilinogen, there is no proper color of the stool. Stool become like a clay, like a whitish color or clay color stool. Pruritus may be in body, may be anus, may be seen. This is the major symptoms of the conjugated hyperbilirubinemia. Grossly, if we seen, liver becomes swollen. Microscopically, bile lakes are present. Focal necrosis of the hepatocytes, accumulation of the polymorphs in the histological section. Neonate jaundice. This is the important, because we have to differentiate physiological jaundice or pathological jaundice. Occurs in infants when total serum bilirubin is increased 3 mg per deciliter. Infant liver is deficient for the enzyme necessary for the conjugation of the, while the rate of the RBC destruction is high. Sometimes because in the infant there is excessive destruction of the RBCs. Initially at the time of birth, hemoglobin level become very high, and after the destruction of the RBCs, the serum bilirubin forms. But in normal conditions, this physiological jaundice may be healed within the 2 or 3 days or within 1 week. Sometimes it is called icterus neonatum, particularly more severe in the hemolytical disease, the newborn, due to the isoantibodies. In this condition, in the form of isoantibodies, and there is severely destruction of the RBCs, may causes excessive hemoglobin breakdown and excessive bilirubin production. If in this condition, if there is essential enzymes become deficient or less in number, like glucosyl S transferase, may produce Rotor syndrome, Crigler-Najjar syndrome, and other congenital disorders of causes neonatal jaundice. When bilirubin level crosses 20 milligram per deciliter, there is a chance of permanent damage of the brain. That is called kernicterus. In this condition, very fatal condition in which excessive bilirubin causes damage of the brain, and this condition is fatal for the neonates. Causes of the neonatal jaundice: unconjugated hyperbilirubinemia due to the excessive RBCs breakdown, physiological and premature jaundice, hemolytic disease in the newborn causes kernicterus. Already told, excessive deposition of the bilirubin in brain causes permanent damage of the brain. This disease is known as kernicterus. When level of the bilirubin very high, 15 to 20 milligram per deciliter. Gilbert syndrome and Crigler-Nazar syndrome. It is called neonate unconjugated hyperbilirubinemia, in which essential enzymes are deficient, which essential for the reduction of the unconjugated bilirubin. In congenital condition, especially Rotor syndrome or Dubin-Johnson syndrome, in this condition, there is conjugated hyperbilirubinemia because the essential enzymes needed for the conjugation in monoglucuronide to diglucuronide, which is absent. So, conjugated form of the bilirubin increased in the children causes Dubin-Johnson syndrome or Rotor syndrome. It is hereditary condition. Infection like hepatitis B or hepatitis C may be associated with this. Biliary atresia and idiopathic causes may be seen. So it is about the jaundice. In last, we discussed about the therapeutic portion or treatment portion of the jaundice or homeopathic management. So next disease is liver cirrhosis. Liver cirrhosis is a chronic, progressive, irreversible liver disease characterized by the diffuse fibrosis. There is extensive fibrosis found in the advanced cases of the liver. Regenerative nodules may be seen, macronodule or micronodules. Sometimes this may be more than 3 mm size. Distortion of the liver architecture. The liver structure or architecture is completely lost. The lobule architecture or lobular pattern become disturbed. Liver may be in nodular form, lead to the portal hypertension and the liver failure. This condition may be irreversible. Initially, liver become enlarged, greasy, steatotic, or sometimes fatty. But in the progressive condition, it becomes shrunken, diffuse, fibrosis may be seen, or small in the size or weight. The causes, especially etiological basis, the causes are alcoholic liver disease, chronic viral hepatitis, hepatitis B, associated with the hepatitis C, non-alcoholic fatty liver, sometimes post-necrotic cirrhosis may be seen, sometimes autoimmune hepatitis associated with the cirrhosis, biliary cirrhosis, metabolic disease like Wilson disease, cirrhosis in the Wilson disease, like hemochromatosis or copper metabolism disturbance, or drug-induced hepatic injury sometimes may be seen. Alcoholic liver cirrhosis is very common among the all percentage of the cirrhosis. After that, post-necrotic cirrhosis, then this is biliary cirrhosis, Wilson disease, hemochromatosis, rare form of the cirrhosis, sometimes seen. Rare form in we seen in Indian childhood type of cirrhosis, or sometimes iron metabolism or hemochromatosis cirrhosis. With the advanced stages, initially liver become enlarged or inflamed, sometimes fatty, but in later condition, in cirrhotic condition, it is macronodular architecture lost, or sometimes it's shrunken or fibrosed. Pathogenesis: chronic injury, chronic inflammation, fibrosis due to the collagen deposition. They form regenerative nodules because between the nodules there is fibrosis seen. So the between the portion of the fibrosis become protrude or propulsed, which gives the nodular presentation, nodular form of the liver. Portal hypertension. The compression on the portal tract lead to the portal hypertension, and sometimes this condition, if in advance, causes hepatic failure. Classification based of the morphology, कैसा वो दिखाई दे रहा है उसके बेस पे, माइक्रोनोड्यूलर एंड मैक्रोनोड्यूलर cirrhosis. Sometimes both type of nodules, small and large nodules seen, called mixed type of cirrhosis. Based on the cause: alcoholic cirrhosis, post-hepatic cirrhosis, biliary cirrhosis, and cardiac cirrhosis. Alcoholic cirrhosis, the main cause is excessive alcohol consumption, direct toxicity of the ethyl alcohol, alcohol consumption for a long period, there is a definite capacity of the liver to consume the ethyl alcohol. But if there is chronic consumption of the alcohol for a long period, causes adverse effect of the liver surrenders, and direct toxicity or due to the any effect of air metabolites may lead to the damage of the liver, produce excessive fatty liver, steatosis of the liver, and finally the cirrhosis liver. Post-hepatic cause after the infection, after the viral hepatitis, or after the necrotic condition, liver functions become disturbed and produces post-necrotic cirrhosis, biliary cirrhosis, as we already discussed, the obstruction of the biliary tract, maldevelopment of the biliary tract, biliary atresia, biliary lacking, or bile cirrhosis, biliary cirrhosis may be seen. Cardiac cirrhosis, if there is congestive cardiac failure or there is congestion of the main tract, superior vena cava or inferior vena cava, or other branches of the heart receives less amount of the blood, and sometimes associated with the hepatic disorders, Budd-Chiari syndrome, portal hypertension. Initially, the cause lies in the heart or heart disease or congestive heart failure. Cirrhosis develop after this. Clinical features: in early stage, there is fatigue, anorexia, nausea, mild hepatomegaly. In late stage, we see associated with the jaundice, ascites, edema, spider angioma. This tract may be seen like varicosity of the vessels, gynecomastia or splenomegaly may be seen. This condition may develop after many of years. Complications develop after many years of the cirrhosis of liver. Cirrhosis is an irreversible condition, and along with the fibrosis and lobular or destruction of the architecture of the liver. Initially, liver becomes enlarged and steatotic, fatty. The hepatocyte cells contain fat vacuolation, functions become disturbed. There is mild hepatitis may be seen, or sometimes liver functions or GOT, GPT, alkaline phosphatase increased. But in later conditions, there is shrunken-ness of the liver, weight of the liver become decreased, extensive fibrosis may be seen, large nodules or small nodules causes damage and destruction of the architecture of the liver, and finally liver failure, hepatic failure may be seen. Complications: portal hypertension, because extensive fibrosis causes compression of the vessels, compression of the portal tract or hepatic veins leads to the portal hypertension. Ascites due to the excessive compression and leakage of the fluid through the portal vessels accumulate in the abdominal cavity, causes ascites. Varices bleeding. Sometimes this engorgement of the vessels causes rupture, ulceration, or bleeding. Hepatic encephalopathy, due to the congestive hepatic failure or CCF along with the hepatic insufficiency, lead to the hepatic encephalopathy. Hepatorenal syndrome, and after if there is multi-system disorder develop, renal system also include, or hepatorenal syndrome may be developed. Hepatocellular carcinoma, sometimes it is few percent cases of the cirrhosis may be turned into the hepatic cancer, 1 to 2% of the cases. It's called hepatocellular carcinoma. This is the stages. Healthy liver, you can see the smooth compact architecture. Then fibrosis lead to the fibrous bands, which causes compression in the hepatic parenchyma or lobular structure, which gives the macro or micronodular consistency. Then cirrhosis, severely shrunken, fibrosed, multilobular, or sometimes nodular. And initially, this few percent of the liver may be involved in this, but in the later condition, the maximum portion of the liver is cirrhotic or may be turned into the 1 to 2% cases turned into the carcinoma of the liver. Diagnosis: laboratory diagnosis: elevated serum bilirubin level, raised AST, LT, low albumin, GOT, GPT may be increased, prolonged PT, prothrombin time, imaging, ultrasound, CT scan, MRI, and liver biopsy may be done due to the confirmation of the cirrhosis liver, or complications may be detected by the biopsy, may be turned into the carcinoma or not. Management, treat underlying causes. Alcohol जो है, alcohol abuse, stop the alcohol abuse. Abstinence, excessive alcohol may causes cirrhotic liver. It is main cause of the cirrhosis. Antiviral therapy in the cases of post-necrotic cirrhosis or after the viral hepatitis B or C. Diuretics for the acids, or aspiration of the fluid from the abdominal cavity. Beta blockers for the portal hypertension for maintain the hypertension or blood pressure. Liver transplant, it is the last treatment if liver is completely failure, so liver transplant may be done with the family members. Or diet and lifestyle should be changed. Low salt diet if ascites is there. Avoid alcohol consumption. Ethyl alcohol may produce direct toxicity to the liver. Some persons drink neat alcohol, and sometimes it alkaloids, its metabolic end product may causes damage of the liver. So stop alcohol immediately. Adequate protein unless encephalopathy is there. Vaccination for the hepatitis, regular checkup and vaccination should be done. Regular follow up this condition. So this is about the cirrhosis of liver. So next disease is hepatitis. Hepatitis means inflammation of the liver. It can be acute or chronic, caused by the viruses, alcohol, drugs, autoimmune disorder. Initially, jaundice may be associated with the hepatitis. Any cirrhotic condition may be associated with the hepatitis, or hepatitis may be many types. Hepatitis A virus may cause hepatitis, hepatitis B, hepatitis C, hepatitis D, hepatitis E, and non-viral hepatitis is alcohol hepatitis, drug-induced hepatitis, and autoimmune hepatitis, in which dangerous form is hepatitis B along with the vitamin D. Hepatitis D may be fatal. Hepatitis B vaccination done in the children or adults also for the prevention of hepatitis B. Causes: viral infection, alcohol abuse, drug toxicity, especially overdose of the paracetamol. WHO recently banned this paracetamol overuse, or the sale of the paracetamol, because its over use or toxicity may produce liver damage. Contaminated food and water, or waterborne diseases, blood transfusion, or unsafe injection, especially in the vitamin hepatitis B or hepatitis D. Mode of transmission: hepatitis A or hepatitis E spread through the orophycal route. Foodborne, waterborne infections, and hepatitis B, hepatitis C, and hepatitis D, it is transmitted through the blood or body fluids, transgenomic, or maybe through the mother to child, vertical transmission. Clinical features in all type of hepatitis. The pathogenesis may be different all type of hepatitis, but hepatitis B is very dangerous type of hepatitis. If associated with the hepatitis D, it may be fatal. Clinical features in all type of hepatitis, it may be severe or moderate. Fever, fatigue, nausea and vomiting, loss of appetite, right upper abdominal pain, especially in the right side of hypochondriac region, dark urine, clay-colored stool, or jaundice. Some symptoms are associated or similar that of the jaundice due to the few features of the hepatitis associated with the jaundice. Hepatitis may be along with the jaundice. So features of the jaundice are common in the hepatitis, like fever, fatigue, nausea, vomiting, loss of appetite, right upper abdominal pain, dark urine, clay-colored stool. Clay-colored stools especially seen in the conjugated hyperbilirubinemia, or this type of jaundice. Pathophysiology: virus entered the bloodstream, reaches to the liver, hepatocyte inflammation may be seen, liver cell damage, impaired bilirubin metabolism, or symptoms of the jaundice are predisposed. So, if vitamin hepatitis A or hepatitis E that is spread due to the food or waterborne infection. So it may be entered in the body through the contamination food or water, and the hepatitis virus B, E, or C, which spread through the hematogenic route, may enter in the through the bloodstream. Then it reaches to the liver, tapped to the hepatic parenchyma, produce inflammation, liver cell damage, and symptoms of the jaundice also. Diagnosis, liver function test, LFT, very important. Elevated ALT and AST level, bilirubin increased, GOT-GPT will be increased, bilirubin level increased, viral markers, hepatitis B/S antigen may be elevated, and anti-hepatitis C virus, especially the anti-hepatitis C virus, or ultrasound may be done. Complications, liver failure, cirrhosis, hepatocellular carcinoma, chronic hepatitis, liver failure, cirrhosis, hepatocellular carcinoma, chronic hepatitis. And basic management is bed rest, adequate hydration, nutritious diet, boiled vegetables, boiled soup, boiled rice, antiviral drugs, avoid alcohol, and homeopathic medicines. These are the management portion of the hepatitis. Now, this is about the major hepatic disorders. The symptoms like Budd-Chiari syndrome, portal hypertension, hepatic abscesses, hydrated cysts, there is many small diseases other than these major diseases, but may associate with this type of diseases or hepatitis also. The major homeopathic medicines used for the liver disorders, that is Chelidonium majus, very good remedy for the liver. Right-sided liver pain, pain radiate from the right to scapula, especially when phrenic nerve may be involved. Very important symptoms of the Chelidonium majus: yellow tongue, bitter taste, liver may be enlarged, pain in the right hypochondriac region, and indigestion. This type of symptoms may be seen in the Chelidonium majus. This is main medicine, important medicine for the liver disorders. It is used in the potency as well as mother tincture form. Cardus marianus. It is very important medicine for the alcoholic liver damage, maybe hepatitis, liver enlargement, portal congestion. Very important medicine for the biliary atresia, gallstones, post hepatic jaundice, and conjugated hyperbilirubinemia. Very good remedy, Cardus marianus. It may be used in the potency as well as mother tincture form. Lycopodium clavis, right-sided remedy, very important remedy, very useful in the hepatic disorders. Bloating after small quantity of the food, there is flatulence, nausea, aggravation time 4 to 8 p.m. Very important in this right-sided complaint from right to left side, liver, blood, urine containing red sand-like particles, liver enlarged, one side of extremity cold and one side of hot. Very important symptoms of the Lycopodium. Phosphorus, it is also important. It is also called hepatic remedy. Fatty digestion of the liver, burning pain, burning sensation in extremities, in body, weak, sensitive persons, excessive craving for the alcohols or cold drinks, juicy substance marked in the phosphorus. In the case of hepatitis, acute or chronic hepatitis, the major remedies are Chelidonium, Bryennia alba, Aconite napellus, Mercurius, Merxol, Chelidonium majus we already discussed, clay color stool, post hepatic jaundice, conjugated hyperbilirubinemia, marked pain in hypochondriac region, Bryennia alba, stinging pain, worse by the movement, dryness, intense thirst, unquenchable thirst, symptoms relieved by the pressure and rest. Aconite napellus, it is very useful for the inflammatory condition of the liver, acute hepatitis, early inflammatory stage, sudden onset associated with the fever and pain in right hypochondriac region. Merxol, jaundice with the salivation, profuse sweating, metal smell in the sweat and stool works for very important medicine. In the case of liver cirrhosis, important medicines are Cardos marianus, important for the ascites and liver pathology, Apis mellifica, ascites with the scanty urine, aurum met, chronic liver degeneration with the depression, phosphorus in advanced liver degeneration. It is also useful in all type of hepatitis. So these are the major hepatic homeopathic management. Along with this, very important, some clinical notes we should use or implement. Always investigate with the liver function test, ultrasound, viral markers before prescribing. In case like viral hepatitis, cirrhosis, obstructive jaundice, refer for the conventional medical innovation. Lifestyle advice: avoid alcohol, restrict alcohol, fatty food, junk food, outside food, use, maintain healthy body mass index, reduce the obesity, some rest, yoga, exercise is essential to maintain the lifestyle, change the lifestyle. So this is very important clinical notes or tips to stop or control the hepatic disorders, diet, lifestyle management, which is also essential for the stop this liver disorders, hepatic disease. Along with this, homeopathic medicine and some important tips essential for the this. So this is about the hepatic disorders and homeopathic management. So if any query you can ask to me regarding this pathology, pathogenesis of the hepatic disorders or homeopathic management. So questions are welcome. Anybody want to ask?
If anyone have any queries, please raise your hand.
Okay.
Thank you, sir. On the behalf of IFPH, I express my deep gratitude to our respected speaker, Prof.Dr. RINKU BISHWAS, for his
Yes.
enlightening and insightful lecture on hepatic disorders and homeopathy. Thank you for sparing your valuable time and sharing your knowledge with such dedication. I also extend my sincere thanks to all the participants. Once again, thank you, everyone. Have a wonderful evening. And now I gladly welcome the moderator of Malayalam section. Thank you, sir. Thank you so much, sir.
Thank you.
Thank you, Anjita KG. First time of moderator, dynamic moderator. Very good explanation and congratulations, Dr. रिंकू विश्वास, बहुत अच्छा हेपेटाइटिस डिसऑर्डर पर बताए, बहुत बढ़िया, और लॉट ऑफ मेडिसिन एंड कॉज curative in homeopathic medicine. Teridonium is a very good, and natrum salt. Natrum salt is a very good remedy hepatitis disorder. So very thanks, Dr. Vishwas ji. And Lycopodium, Natramure, Teridonium, it is a wonderful medicine and beauty of homeopathy. Liver is a second brain. Liver is a second brain. Or hepatitis disorder, difficult treatment. So homeopathic is a easy treatment. Homeopathic easy treatment in liver disorder. So very thanks, Dr. Vishwas ji. Thank you. घर घर होम्योपैथिक, हर घर होम्योपैथिक.